Hello everyone and welcome to another in our series of video chats. Now, for anyone watching the Euros this summer, one of the most dramatic moments had to be in Denmark's opening match when their midfielder Christian Eriksen suddenly collapsed on the pitch. Now, Eriksen had suffered from what's known as sudden cardiac arrest. Now, thankfully, he was resuscitated on the pitch, and after spending some time in hospital, he actually returned to Inter Milan earlier this month, although not to play just yet. Now, that case drew quite a lot of attention to the condition, but sudden cardiac arrest is not uncommon and impacts around 30,000 people a year in the UK, many of whom are under the age of 25. So today we're joined by Professor Craig Williams, who is a Professor of Paediatric Physiology and Health at the University of Exeter, and also the Director of the Children's Health and Exercise Research Centre. And some of his research has been looking at congenital heart disease and cardiovascular risk in young athletes and how it can be reduced. So welcome, Craig. Thanks so much for joining us.
Hello, everybody.
Now, could I start with what's hopefully a simple question for you, but what is sudden cardiac arrest and how does it differ from a heart attack?
Yep, so they're not one and the same. They are subtly different. The sudden cardiac arrest really occurs when the heart has a problem with its electrical system. And what happens is that electrical system becomes chaotic and the heart malfunctions, and then suddenly you get a very irregular heartbeat. And often this heartbeat will beat dangerously fast. And what happens is the bottom chambers of the heart, the ventricles, end up fluttering or quivering, and this is called ventricular fibrillation. And so there's a lack of blood that's being delivered to the body. And of course, in the first few minutes of an arrest, the greatest threat is the blood flow to the brain, which will be reduced. And if that reduction is so dramatic, then a person could lose consciousness. And of course, if the emergency services can't get to that person quick enough, death can follow. Now, a heart attack is different because if you think of it as a problem with the plumbing of the heart, so there might be some sort of obstruction in one of the coronary arteries around the heart where blood flow is restricted. But in some senses, the heart can cope because it's got other coronary arteries around the heart that can still deliver the blood and the oxygen to the heart. That's not to say if the obstructions become so great that the heart attack could cause a cardiac arrest and then have some of those electrical abnormality problems that I described a moment ago, but they're not one and the same. Sometimes they are confused as being similar.
Brilliant, thank you. And is there anything that makes a person more at risk suffering from sudden cardiac arrest?
Well, probably the key things are if a person has had a previous heart attack. Now that's not likely to happen with, say, our young athletes, but that's more common in maybe an adult or elderly person. And of course, if you do have coronary artery disease, particularly as I mentioned, those obstructions getting greater and greater, then that can result in sudden cardiac arrest. But probably the key risk factors are things like family history. So it's important that people know, have they got immediate relations, fathers, mothers, grandparents, siblings that have had some particular problem. There are obviously many conditions such as congenital heart disease conditions. So one of the most common is hypertrophic cardiomyopathy, and this is a thickening of the cells and the cell walls, which can affect the sort of flow of blood in and out the ventricles. And then, of course, you have other aspects such as things like obesity and diabetes. And of course, there are some known causes of recreational drug abuse that can be risk factors for sudden cardiac arrest.
Brilliant. And you mentioned some conditions there. I mean, is there anything that can be done to identify potential problems before they strike?
So knowing some of these risk factors, we can obviously screen, and this is some of the work that we're involved in with Manchester United Youth Academy Football Club, which is screening all its young athletes. So I mentioned a number of risk factors, and of course one of the others is ethnicity, because we know there are some differences with Black American and Black African, Black Caribbean groups compared to white ethnic groups. So if we're able to screen for the personal and the family history, if we know a little bit about their ethnic groups and backgrounds, if we know perhaps some of their genetic makeup, then we are able to try and risk stratify or score the potential for some of these things to possibly strike in the future.
Brilliant. And if you do identify risk, is there anything that can be done to reduce that?
Well, what we would try to do is screen for these things using standard tools such as an ECG. So this would be an electrocardiogram. This is a standard piece of kit that's used in hospitals to assess the electrical activity of the heart. It's done at rest, it's non-invasive. The athlete or the patient just lies down, and we can take a reading within sort of 30 seconds. And that gives us plenty of information about the electrical voltage of the heart. And we can see certain patterns which might be indicative of certain aspects like hypertrophic cardiomyopathy or some other conditions like Wolff-Parkinson-White syndrome. These are things that can be picked up on ECGs. We can also do what's known as an echocardiogram. So this is using ultrasound, very much like we use for when pregnant mothers look at the fetus, but this time we're obviously ultrasounding the heart. And again, it's non-invasive, patient lies down. We can ultrasound the chest and we get the images of the heart. We can look at various measurements, the thickness of the heart, the size of the heart, the thickness of the atria, that's the upper chambers of the heart, or the ventricles, the lower chambers. And we can look at norm references to see whether or not they're in acceptive values or whether or not they're abnormal, because one of the adaptations of training is that your heart gets bigger and it gets thicker. But obviously, if this continues on to such a degree, it could actually become abnormal. It could actually interfere with the normal functioning of the heart. And this is some of the work that we're trying to do in screening and looking at these values with our young athletes. So we'd perform a history, a personal history, a family history, some basic anthrometrics, height, weight, skin fold type circumferences. Then we do ECGs and echoes to try and mitigate against any potential risk for sudden cardiac arrest.
Brilliant, thank you. Now, so you work with young athletes, you mentioned Manchester United. Are there different strategies for children and adults? And if you do identify risk in children, can they still carry on competing in sports?
Well, there's a very big debate at the moment going on where, for example, in countries like Italy and Israel, it's mandated for youth athletes to have an ECG prior to any sports participation. Now, in mainland other European countries and the UK, we don't mandate for an ECG for our young athletes in sports participation. And that's felt because doing the sort of family histories and personal histories is giving sort of similar screening statistics. However, a number of sports organizations, including FIFA and the English FA, are now beginning to mandate for ECG for youth academies. So in youth academies, we are now seeing the use of ECGs more regularly, certainly on an annual basis, to ensure the health of a young athlete's heart. And this is not dissimilar to adult athletes who would have this as part of their professional contracts and medical screening. For example, if they're signing for a new club, they will go through a full medical. So really, our argument is much that we shouldn't really treat the adult athletes any different to young athletes.
Yeah.
Although sudden cardiac arrest and death is a rare occurrence in our young people, it does happen, and it's obviously very traumatic when it does happen. So really trying to think about how we can embed these protocols and screening services either within an NHS service or within a sporting organization is challenging, because you really need appropriate trained cardiologists who are used to looking at the pediatric heart. So my two cardiology colleagues who collaborate on this project, Dr. Graham Stewart and Guido Pielas, based up at the Bristol Children's Hospital, are experts in really looking at a child heart, and that's child whether or not they're a school athlete or whether or not they are in a professional rugby academy or football academy or cricket academy. And there are probably not enough pediatric cardiologists around the country to have every single UK youth athlete screened. So it is a challenge. There are some charities around, such as Cardiac Risk in Youth, which do have free screening services. But again, we really need to think about how we can embed some of these services. It's a bit similar to the arguments now about really we should make sure that we have a automated external defibrillator at all sporting events and schools, so that if there is a sudden cardiac arrest, the defibrillator can be life-saving if we can attach it to that person and help save their lives. So it's not without its challenges at the moment.
Yeah, I was going to ask about defibrillators because we saw that immediately on the pitch in the case of Christian Eriksen. And I mean, how important is access to something like that kind of equipment when it comes to actually saving someone's life? It's
absolutely crucial. It certainly saved his life. And probably in the example of one of the most famous cases, Fabrice Mwamba, who was playing in an FA Cup tie. It was actually a cardiologist in the crowd who jumped over the hoardings, who recognized what was happening and was able to initiate CPR and then the defibrillator that saved his life. And one of the suggestions is that the survival rate drops between 7 and 10% every minute without a defibrillator. So it really is life-saving to have that defibrillator on. And of course, the great thing about the defibrillator is it's relatively easy to be trained. So you and I could be trained to use this in a sort of a morning or day's training. And the actual device talks you through how to actually attach the electrodes, when to press the button. You can't do any harm to it, because if the device detects that it's not ready to shock the particular person who's having the cardiac arrest, it won't do anything. So you can't do any harm by actually having the device attached to the person. So it is really, really crucial. And I know there are many organizations now that are really trying to put defibrillators at major public arenas, train stations, shopping centers, and as we mentioned, in schools. So I think it is absolutely critical, as well as the same as teaching our young pupils how to do CPR. Even if a defibrillator is not present, then doing CPR quickly until the emergency services arrive can save lives.
Brilliant. I just wanted to ask one final question. You've been working with sporting governing bodies and looking at responses. What do you hope will come out of your research in terms of new protocols or processes or anything like that in the future?
Well, we're hoping, obviously, to keep flagging to sports organisations that there still isn't enough focus on the paediatric athlete. We know comparatively less compared to the adult athletes about their general physiology and heart health and the interventions of exercise and sport. So we're hoping to better refine these protocols. And in fact, at the Manchester United, the types of screening that we're doing, I think, are some of the best in the world. And we've expanded that work to Barcelona, and also to some of our cooperation with the Qatar Sports Aspire Academy. So we hope also to increase the database for reference values and numbers, so that we will understand better what's abnormal, what's normal, and indeed what's pathological. And because we are also including young patients who have congenital heart disease, who are actually encouraged to take part in some exercise, we'll be able to really look at and advising them better as to what exercise is better for them, and perhaps which sports or exercise are probably not a good idea because of their congenital heart condition. Of course, doing that type of research, because of the involvement of medical colleagues and ensuring that insurance and these type of things are in place, is costly. So, you know, I think it will allow us to give us a better understanding of these physiological changes that are taking place, either due to training or just normal school physical activity, or for our young congenital patients as they're aging and wanting to get into a bit of sport. Hopefully these preventative type strategies will pay off in the long run, because they'll have a better quality of life. Potentially there'll be less hospitalization, maybe their medication might be reduced, etc. And obviously for those athletes, it's really about ensuring as much as we can do to try and prevent any event happening. And of course, we can never do that 100% of the time, because we know from statistics in the UK, there are approximately 12 deaths every week in apparently healthy and fit young individuals under the age of 35. So, you know, sadly, it's still occurring. These are mostly undiagnosed cardiac conditions. So there is still a lot more to try and investigate about why those types of things went undetected and undiagnosed, and is there anything that we can do more to try and reduce that number?
Brilliant. Well, thank you so much for your time. That sounds really, really interesting research and really impactful for so many people. So thank you for taking the time, Craig. And we will be back with more videos very soon. Thank you very much.
Thank you very much for listening.